All right. Hi, Maria. Can you hear me? Good afternoon, everyone. I hope everyone is able to hear me. My name is Rita Gayed, and I am the president for the Southeast chapter of SCCM. I'd like to welcome all of y'all to our August quarterly education meeting. We typically start all our meetings with the chapter mission and vision. Okay, perfect. Thanks for the confirmation that you can hear me. Our mission is to secure the highest quality of care for all critically ill patients and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. And our vision is that all critically ill and injured persons in the Southeast region will receive care from a present integrated team of dedicated, trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. We will start off the meeting today with announcements regarding upcoming chapter events to look out for in the fall and in the winter. So September is Sepsis Awareness Month. Due to COVID, unfortunately, the chapter is unable to host an in-person event. However, Sepsis Alliance is still hosting the Sepsis Awareness Superhero Challenge during the month of September, where participants are asked to virtually complete 1 mile, doing whatever activity they'd like. So that can be running, dancing, cycling, hiking, whatever you'd like, jogging, walking even, and that will actually swimming. That will actually help raise funds for sepsis awareness programs and initiatives. Please be on the lookout for more information via chapter emails regarding how to sign up for that. In October, our chapter will be hosting the last quarterly meeting for the year. Our guest speaker will be Dr. Matt Suba, who will be talking to us on driving pressures and the management of ARDS. This meeting will also be held virtually via GoToWebinar on October 14th. So be on the lookout for more announcements on that, on how to register for the meeting. The chapter is also planning on hosting a Twitter journal club as well as a bite-sized lecture in the fall. The bite-sized lecture will be on the multi-professional management of GI bleeds. So it should be a very educational talk that usually happens around noontime, around lunchtime. Lastly, the chapter elections will take place by the end of this year. So be on the lookout for emails regarding the new electees and information regarding how to vote. One last housekeeping item for today's meeting. Please make sure to fill out the CA survey within 2 weeks of the meeting today. So that's two days from now. Physician, nursing, and pharmacist and dietitian CE is offered for all chapter members who are attendees of this meeting. Without further ado, it is my great pleasure to be introducing tonight's speaker, Dr. Greg Martin, our SCCM president. Dr. Martin is a professor of pulmonary and critical care medicine and an executive associate division director at Emory University in Atlanta, Georgia. Dr. Martin directs the Emory Predictive Health Institute. He co-leads the Atlanta Center for Microsystems Engineered Point of Care Technologies, and he serves as the research director for the Emory Critical Care Center and as the chair of critical care medicine at Grady Memorial Hospital. Dr. Martin's research focuses on sepsis and the acute respiratory distress syndrome and spans epidemiology as well as health service research through device platforms and biomarker studies to randomized trials of new treatments. This year, Dr. Martin is serving as the president for the Society of Critical Care Medicine, the largest multi-professional organization in the world dedicated to the care of critically ill patients. Dr. Martin has been a longstanding member of our chapter. He's been a huge supporter of the chapter. We feel extremely privileged to be able to host you tonight as our president. And with that, Dr. Martin, I'm gonna give you the screen as well as the mic.
Thanks very much, Rita. And it really is a privilege, and I certainly appreciate the opportunity to speak. I really do, from the society perspective, love the fact when chapters take advantage of having the presidents and the other leadership come and speak. It's a great way to connect and also a great way to get together and learn from each other. And obviously, from my perspective, it's really fantastic to be able to speak to the Southeast chapter, where I've been. I've lived for 20 or more years, and I've really loved to see the way the chapter has grown and flourished over the last year. So without further ado, I'm going to talk about the future of critical care, which is a bit of a different topic or a different talk. So if you can let me know, make sure you can see my slides.
Yes, we can.
Okay, perfect. So this is a bit of a different talk, and I appreciate the very kind invitation, and obviously appreciate the opportunity to speak about a topic that's a little bit different. So I don't have any other conflicts of interest. Those of you that know me, and I really do appreciate those that I see on the call or on the meeting this evening, because I know a lot of you I've already met, and I hope to meet even more over the next few months and years. Most of my time is spent doing research in things like sepsis and ARDS, as well as COVID-19. And as Rita said, I have the privilege of serving as the president for the Society of Critical Care Medicine this year. So here's what I intend to talk about for the next bit. And first is we're going to talk about where are we now. When we're thinking about the future of critical care medicine, in every context, from a historical perspective, it's important to know where we are and how we got here. And then also thinking about what are the things that are going to influence our next direction. And then with that in mind, where might we see ourselves in 5 years, in 15 years, and in 30 years? So having said that, a look into the future really needs to start with the past, because we have to, again, understand where we've been, but also how quickly critical care is changing. And I'll show you some reasons to think that that might be an important factor in where we're going. So let's go backwards a little bit in time, almost a couple hundred years now, and think about what's the first ICU. And I put that in quotes because obviously it wasn't called an ICU at the time, but Florence Nightingale during the Crimean War in the 1850s recognized that the sickest patients needed more attention and that they would do better, their outcomes would be better if they got that. So she demanded that those patients be placed in beds closer to the nursing station where the intensity of monitoring and care was going to be greatest. And this was really the first example of geographically cohorting the more critically ill patients. And then in 1932, Walter Dandy opened what was called a specialized 3-bed neurosurgical unit at Johns Hopkins in Baltimore. And this was still not necessarily called an ICU, but it was cohorting critically ill patients, and it was also cohorting patients according to disease type to better characterize or better cohort them so that they could receive more similar care when you have the same level of training and capabilities for monitoring and managing the patients. And then over the next sort of 20 years after that, ICUs began to develop around the world, but mostly related to two phenomena. One was natural or man-made disasters, that is basically World War I, World War II, but then also the other disasters, which was particularly the polio epidemic, which spanned the globe and became a pandemic and was obviously in some ways maybe the force that created our specialty or cast our specialty, particularly with the advent of mechanical respirators. And then thinking more specifically about ICUs in the United States, you may know doctors Max Harry Weil and Herbert Shubin, and Max was the SCCM's first president 50 years ago now, who opened a 4-bed shock unit at the Los Angeles County USC Medical Center in 1958. So again, that same time frame, right around when we began to understand what could be put in place for World War II and for the polio pandemic. And then Peter Saffer, who was SCCM's second president, started the first around-the-clock physician-covered ICU at Baltimore City Hospital around the same time. Now, the other part that's important when we think about what's happened in critical care and the evolution over time is the technology that goes along with it. And this is particularly important for critical care because much of what we do in critical care and the things that we've developed to support and sustain life and save life has actually been focused around technology as much as it's been around the providers and the expertise and the education that we have. So for instance, dialysis, which began in the 1940s, not in the ICU, not the thing we think of now as renal replacement therapy, but conventional traditional dialysis began quite a long time ago. Mechanical ventilation really came to fruition in the polio pandemic. And then things like cardiopulmonary bypass, ECMO, really conventional, more renal replacement therapy in terms of continuous use, and even things like the molecular adsorbent recirculating system, which then raises the question, thinking of these technologies and particularly the support systems that have been put in place. What are things going to look like in another 5 years or 15 years or even in 30 or 40 years? So if you think about it that way, it took it took thousands of years for Florence Nightingale to take that first step of putting sick patients together near the nurses who are providing that continuous level of care. Then it took another 80 years to develop that first 3-bed post-operative unit, another 30 years to develop the first modern ICUs with just a few beds, and then 20 years to begin developing the support devices that we now see and use routinely in the ICU. So if you think about it in that way, the question becomes, well, how fast can change really happen? And I will point out that even though I don't feel that old, a lot of things have changed even in the time since I was in college. So I used what was called a compact and portable computer, which was, as you see there in the upper right-hand corner, was a computer that had disk drives and had a keyboard that you could fold in and then a handle on it that you could carry it, but it weighed about 35 pounds. So particularly not portable by today's standards. We also didn't have cell phones. We didn't have YouTube. We watched things like MTV. There was obviously no Spotify, no streaming. The other things that happened while I was in medical school, some of which don't seem that long ago, was the introduction of the left ventricular assist device, the cloning of the hepatitis C virus, and yes, in fact, the launching or the creation or the really sort of widespread access to what was then called the World Wide Web, what we now refer to as the internet. So with those things in mind, then changes are definitely occurring very, very fast. And when you're thinking about it from that context, how do we foresee the future? And there's obviously a danger in predicting the future because there's several alternative futures that could change depending on external forces, internal forces, natural and man-made disasters, technological developments, and others. So on the left-hand side, you may say, oh, well, there's this beautiful gleaming city, or maybe there's a slightly less gleaming city, could be either of those. It could be a Hollywood version of the future that might look quite different again. And as you see at the bottom, Casey Stengel, I think, was quite wise to say that you shouldn't make predictions, especially about the future. And that's really encapsulates the challenge that we have in trying to understand what's going to happen. So in one way, the future might look like this. This is Walt Disney, who had this vision that the future would look like spaceships and space travel. And even though he never lived to see it, this was actually quite prescient. In many ways, he was very correct in the way things moved, that there were rocket ships, things orbiting the Earth at all times, and people traveling, as we know now, beginning to think about whether we may travel to Mars. But Hollywood might have alternatively thought about it as this, and this would be the alternative scenario from Back to the Future, where they envision people traveling on hoverboards and zipping around town, and obviously not the reality that we live in today. So predicting the future is not precise, and the Chinese have a wonderful quote for this, which is that those who have knowledge don't predict, and those who predict don't have knowledge. Now, having said that, I'm going to go out on a limb and still try and make a few predictions and at least base some of that on what we know. So I'm going to talk about where we may be in 5 years, in 15 years, and then in 30 years. So when thinking about that, the first thing is to think about what are the external forces that affect critical care. And these are the things that we're all seeing every day. For instance, this increased demand for critical care services. Even before the COVID-19 pandemic, we were seeing an increasing demand. Many hospitals were building more ICU beds, but there's also greater acuity and complexity to those ICU patients as well. So that's not just more volume, but also more acuity that goes along with it. The other external forces are computing capability, scientific discovery, which has been a real rapid pace over the last really 20 or more years. And then things like the emergence of machine learning and artificial intelligence, as well as the emergence of the Internet of Things, which allows connectivity and communication across a wide spectrum of devices that can be both patient-centered and hospital-centered. So let's think about where we may be in the next 5 years. And particularly in the next 5 years, what I suspect we're going to see most is the better application of existing ideas, the area where we have data or evidence that suggests that things are going to be effective, and we really need to apply those and begin using them. So implementation of existing data, things like less sedation and more early mobilization, point of care ultrasound, the widespread use of advanced practice providers in the ICU, and then telehealth, telemedicine, or EICU systems. So starting with the first of those, the application of existing evidence. Sepsis, one of the most common conditions we deal with in both the adult and pediatric ICU space, is very clearly improved with things like the Surviving Sepsis campaign. So this one example, which is not by any means the only, has 30,000 subjects from over 200 hospitals, which showed that the application of the bundles that come from the campaign as resulting in better outcome, a lower mortality, and really better outcomes in terms of disposition as well. And that a lot of that translates from the amount of compliance with the bundle. So the greater compliance with the bundle elements, there is a greater reduction in mortality. That same thing can be said with the ICU Liberation campaign, or what you may think of as the A to F bundle, A, B, C, D, E, F. And this is an example where what you see on the y-axis is greater hospital survival, and on the x-axis is compliance with the bundle. And clearly, the greater the compliance, the greater the survival, to the point that survival, even among critically ill mechanically ventilated patients, is over 90% if you have consistent application and compliance with the A to F or the ICU Liberation bundle. So in this case, hospital survival increases by almost 25% for every 10% increase in bundle compliance. The other things that we definitely will see more of, and I'm really proud to see so many places around the Southeast and even around the world now doing this, is early mobilization, getting patients up and walking. And this becomes a really increasing need for our patients because it has effects not just on rehabilitation and recovery from illness, but also on things like delirium and neurocognitive deficits that can occur from people who are deeply sedated or remain in bed for prolonged periods of time. And if you're familiar with the Choosing Wisely campaign, which has been around for almost 10 years now, the next 5 elements from those actually came out earlier this year, the very beginning of 2021, and you can find those from Jerry Zimmerman in Critical Care Medicine. And the next 5 includes early mobilization to make sure we're doing that consistently in every patient in the ICU as much as possible. Point of care ultrasound, the next thing that we'll think about, and this is one where we've all seen ultrasound, and if you've been around ICUs very long, you recognize that ultrasound looked like this not that many years ago. They'd roll this big machine to the ICU. I'm sure many more of you are familiar with this form where it's a much smaller form factor. It can roll to the bed, and in fact, in some ways, it becomes portable with a handle on it. But fast forward not very far, and where we are now is really having a simple ultrasound probe that can be plugged into really almost any device with the app that runs, and then you have ultrasound images available really anywhere you walk. So you can go to any bedside and see a patient and immediately have ultrasound images for point of care ultrasound. And this really changes the face of critical care because it can be at least diagnostic and sometimes even lead to important therapeutic changes. The next thing in the next 5 years is really this continued growth in critical care demand being matched with an increasing utilization of advanced practice providers, meaning nurse practitioners and physician assistants as a key part of that solution to delivering the workforce needs. And that's not just bringing them into the ICU and putting them to work. It's also ensuring that they have the training and the capabilities for working there efficiently and feeling comfortable in that environment. So in many ways, just like in other specialty training, competency-based training is key. We're seeing more and more accredited residency programs growing, and I know many of you are familiar with them around the Southeast, particularly at Emory as well. But as you look at that, what you see is that the training programs, and as they specialize into them, are becoming more and more similar to other ICU-based training curriculum, where we're delivering not just the education, but using things like simulation and doing competency-based training. And then finally, the last thing I'll talk about for the 5-year component is telemedicine. And we know that telemedicine rolled out. It exists in more than 10% of all critically ill adult patients already. That was before COVID-19. The federal government and also a number of places around the world have really deployed more telemedicine and telehealth systems during the COVID pandemic. We're optimistic that many of those will continue, whether they continue with full government support or whether they continue because of the clinical need for the patients is something yet to be seen. But we know that telemedicine has the capability not just to expand the workforce, but also to provide better outcomes for critically ill patients. And this is in one way, many of you may be familiar with Tim Buckman and Cheryl Hiddleston, who are deployed or working in our bunker here. And one way to think about this, and particularly as we think about telemedicine, one of the most common scenarios is need for nocturnal coverage, meaning the need for monitoring patients or an additional set of eyes helping to manage patients at night when there are fewer providers or fewer other people at the bedside. And in many ways, that nighttime staffing can be difficult, but one of the things that Tim and Cheryl deployed was moving staff 12 hours apart. So moving them to Australia, where if they're working during the day in Australia, that turns out to be nighttime in Atlanta, Georgia, and therefore you can monitor those nighttime patients and still be working during the day. Okay, so where might we be in 15 years? And this becomes a step beyond what's already known, but also thinking about what's completely plausible. And the things that we already see, things like contactless patient monitoring, closed loop systems, pulling things together to be able to deliver immunomonitoring and potential immunotherapy, tiered regionalization, and critical care sub-specialization. So the first of those is this contactless monitoring and deployment of different sensors. And many of you are familiar that we've seen more and more evolution of sensors over time, from the simple sensors that simply can measure something but can't necessarily convey it anywhere, can't communicate it, can't do anything with it, to now sort of the more level 3.0 or version 3.0 sensors that do more than just data gathering, but they do it passively, continuously, very energy efficiently. And they actually can do aggregation of data, pull it together, report it, and even do some meaningful interpretation of it. And so there's a variety of things that you're probably beginning to see. This is one example where you can have contactless monitoring to see perfusion change over time. And this is simply a camera that sits over the bed. If I can get this to play for you. A camera that sits over the bed, and it will monitor changes in perfusion that you can see in the veins and arteries in a person who's laying in bed. Similarly, you can pick up non-invasive respiration. We all have seen this, particularly with the COVID pandemic. We've all seen pictures of sneezes and cough and how far those molecules and aerosols may go. But we also can do that from a monitoring perspective in critically ill patients, and we can monitor respiration non-invasively, very, very simply in many ways. And in fact, there are non-contact monitors that already exist, and I'm not arguing for any specific system, but there are some that you simply slide under a patient and they can give you monitoring of the basic vital signs. But you don't have to go very far to get to something that's called a wearable, meaning in this case, sort of a 2-lead thing that would stick on the skin, on the chest, and you can get from that single lead ECG, heart rate, respiratory rate, skin temperature, but you can also get things like body position, whether the patient is moving, if the patient is walking, you can get ambulatory information. If the patient is supposed to be in bed, you can get information about whether they're trying to get out of bed and therefore do fall detection as well. And then what I call any wearables, which meaning something that's not just wearable, but could be deployed anywhere. And these are the kinds of things we're beginning to see really in an experimental setting where you can print the wiring or the capacitance system to detect things on the skin. And you can see these already. There are, they look like tattoos that can be printed and applied to the skin, but you can do them for exposure detection for different people. But in the ICU or in the hospital, you might think of it as a way to monitor drug delivery or even kinetics so that you know what's happening in a patient at any given time with what's going into their bodies. It doesn't take much of a leap then to think about these closed loop control systems and how, for instance, we already see glucose monitoring, insulin infusion, and the only real separation between the glucose monitor controlling the insulin infusion is the FDA and the approval to take that out of the caregiver's hands and allow that to happen automatically. But that's just one step. We've come a long ways towards getting there, and you can then begin to see how we might be able to do the same thing with measuring blood pressure and the administration of vasopressors, or even things like gas exchange and respiratory mechanics that would lead us to being able to set respiratory mechanical ventilation systems, or even guiding renal replacement therapy from continuous or at least reasonably continuous measurements of electrolytes and other measures of flow and hemodynamics. If you begin to think about monitoring at that level, you also can begin to think about immunomonitoring. And one of the things that is the challenge, particularly in the heterogeneous patients we have in the ICU, I'll use sepsis as maybe the best example, is that all those patients have an inflammatory response. They all have a counter-inflammatory response, but the timing and the way those balance in each person is different. So we don't know at any given time whether the person in the room is having a more inflammatory or more anti-inflammatory response, and what the balance of those mediators is at any given time. And in general, if you're thinking about what to do about that, you wouldn't want to give, for example, corticosteroids to someone who's deeply suppressed and suffering from immune paralysis. And by the same token, if someone was hyperinflammatory and suffering from that, you would want to maybe consider ramping down their inflammatory response. And we're beginning to see things like that with COVID-19 as we're measuring biomarkers and trying to understand how to use immunomodulatory therapy as those patients are critically ill. The other things that we'll see in the next 15 years, the first is tiered regionalization, which we see already with things like, clearly with trauma. We really also see it with acute MI and stroke, where patients are transferred to the centers that are specialized in that, have the capabilities for it. For instance, have a stroke center or a cath lab that can handle these patients. And the purpose is to specialize and devote those services or those resources to patients so that you've got the right patient going to the right level of care at the right time. So a major trauma patient would go to a level 1 trauma center. A patient who has minor trauma, you wouldn't want to send to that level 1 center, but you may want to send them to a level 3 center, for instance. And you don't want to be sending inappropriate patients to those places, because then you're not going to get the right level of care and the resources would not be available for them. And then the last thing in the next 15 years is really subspecialization. So if you look back, and you don't have to look back very far in medicine, but certainly looking back just 100 years, you see medicine diverging into 2 major branches, medicine and surgery. And then very quickly into divisions, things like orthopedics, OBGYN, dermatology. And within those now subspecialties, cardiology, infectious disease, pulmonology, and now also subspecialties, cardiac electrophysiology, maternal fetal medicine, dermatologic oncology. Those things continue to happen, particularly in the US, but globally as well. And we now have in critical care all these different areas of subspecialization: trauma, burns, pediatric, neurosurgical, cardiovascular, medical, all those different ICUs, and even more, some are dedicated to transplant or orthopedic ICUs as well. But as a specialty, we're going to continue to see the evolution of subspecialties, because as complexity rises and as volume rises, the need for providing care and the ability to provide subspecialized care to produce better outcomes will continue. The key here is to make sure we're maintaining those common core competencies, because there are very common themes about how we manage critically ill patients, in addition to the nuances or the other elements that go along with very specific patient types. So, having talked about 5 years and 15 years, now I hope some of you are Star Trek fans, because we're now getting to maybe projecting into the future and thinking about where might we be in 30 years. And this becomes obviously more challenging to think about what is the scenario that critical care going to look like in 30 years. So there's a number of potential scenarios, and clearly we're getting more conceptual. There's less support for understanding exactly what it's going to look like. But if you look back to where we've been, clearly the things that we've done to improve survival and improve outcomes and even improve patient outcomes, patient-centered outcomes, is providing organ support. We can support the lungs, we can support the heart, we can support the liver, we can support the kidneys. There's still organs that we can't support as well, and our organ support systems are still far from perfect. But beginning to think of novel organ support systems, we could do so much better if we could support them better. And certainly if we could support really maybe the last mile or the last bastion of supporting the brain. If we could support the brain, imagine what critical care would look like if we had brain support modalities available to us in the next few years. Don't think too much about hibernation, because you might think that that's still a dream, but in fact, I'll show you that there's actually evidence to realize that we're not as far off as we might think about hibernating human tissue while either waiting for recovery or even helping to reanimate and recover those organs ourselves. And then the other part is thinking about all the data, and we know that the ICU is one of the most data-rich environments, is taking all those data, integrating them together and using them for analysis so that we can begin to predict things like decompensation and the onset of organ dysfunction, as well as eliminating things like false alarms and alarm fatigue. And this is really important because, again, if you think about what critical care might look like, if you can predict organ dysfunction and decompensation, critical care suddenly looks very different. So as an example, we know that sepsis is organ dysfunction due to that dysregulated host response from an infection. But if you can predict and change the immune response and you can predict the organ dysfunction, you almost certainly can do something about it. And if you can do something about it, then sepsis no longer exists because the organ dysfunction will never occur. We also need to think about robotic ICU care. We see that in the ORs already. It's being used actually in other places as well. And whether it may begin to occur in the ICU is not by any means a pipe dream. And lastly, the patient-centered elements of individualized and personalized care, because certainly we're all trying to get to more individualized, personalized care, particularly in the ICU, but that also still needs to be very patient-centered, and having the patient at the center of all that is going to be really important for the research we do, for the outcomes we're looking for the decisions we make in trying to support and recover those patients. So I told you that I would mention human hibernation. So we know already that we can take mice, we can basically put them to sleep or kill them and cease all forms of life, and then reanimate them after 6 hours, and they remain functional and vibrant. We also know that we found several genes that are the key genes for hibernation in mammals. So if we can do it in mice, and we found the genes that begin to tell us how that works, it begins to make you think that maybe human hibernation is not impossible. And in fact, there's fossil records, and this is maybe more of an archaeologic phenomenon, but there are fossil records that suggest that our ancestors may have actually hibernated, or at least slept for long periods of time during the winter when it was cold out, because they didn't have the food resources, they didn't have the ability to get out and hunt and be able to survive. So they took more time sleeping. And that's maybe is an indication that some of those genes might still exist and might be functional even in humans. I don't know that your ICU doctor of the future is going to look exactly like this, but I would not think too far about whether you wouldn't see a robot in the ICU in the future. So conceptually, if a robot can facilitate doing surgery, and particularly if you watch the NBA playoffs, you probably saw a robot that came out on the court and was able to shoot a shot from the free throw line, from the three-point line, from the half court, and it did it with 100% accuracy. And conceptually, that makes sense, right? I mean, all you're doing is calculating distance and force, and you're throwing a ball across an arc that you can calculate with physics. For a robot to do that consistently every time is very easy. So there are things that we could do in the ICU, and I don't think it's necessarily going to be approaching a patient with a stethoscope, although we do have sensors that can begin to listen to respiratory sounds and do something with them. But what about some of the more common procedures we do? We already use things to facilitate conducting CPR, where we have a machine to help deliver the compressions that we use. But what about things like central venous line placement, which is visually and mechanistically difficult for an individual? But if you think about the steps involved, it's actually very simple in rows. So it's a matter of finding the vein, visualizing it, and then approaching it with a catheter or a needle the same way every time. And a robot can do all that with the sensors and with much better accuracy than could a human. And then I mentioned CPR resuscitation, and there's clearly the potential for new or better ways of doing CPR resuscitation. And if I can, I will see if I can get my video to play. So this is from Passengers, which was the Jennifer Lawrence and Chris Pratt movie, which is not going to play for me now. Let's see. There we go. So if you're familiar with this, well, it's still not going to play. If you're familiar with this, Chris Pratt, trying to save the spaceship that's traveling to another galaxy, ends up suffering significant injuries, and Jennifer Lawrence is able to carry him in and put him into this glass pod. It's basically an automatic doctor or a treatment pod. And she basically says, cardiac arrest. She pushes all the buttons, and then the device does all the diagnostics and figures out what he needs. And it delivers breaths, it delivers counter shocks, it delivers medications. It does all the things that you would need to deliver CPR. And I don't foresee us carrying our patients and putting them into a pod, but you can imagine a variety of ways that we could improve the CPR that we do now and using technologies to do that. And then the last thing I'll talk about is personalized medicine. So again, this combination of data, particularly the data we generate in the ICU, and the accelerating computing power, the application of machine learning and artificial intelligence, and then the scientific advances that we're seeing is going to make it possible to deliver those personalized care that will be very patient-centered at the right time for each patient at every point in their illness, meaning that critical care and critical illness will not be the same as we see it today. So that evolution has a few steps. And when you step back and say at the very basic level, we have descriptive analytics, which tells us what happened. And so it's very much focused on hindsight, tells us what happened, but it's already in the past. We have things like diagnostic analytics that can tell us why something happened. And now we're getting closer to the present. But then if you think about predictive analytics, it's really what we're focusing on now. What will happen? Meaning it's giving us the insight and the thought into what's going to happen next. And we're having tons of algorithms, tons of tools that help us to predict what's going to happen. But where we're trying to get to is prescriptive analytics, meaning predicting in the future, but not just understanding what's going to happen and why it happened, but actually controlling how it happens so that we have the ability to control how it happens, making it happen, or even forestalling it so it doesn't happen. And getting to that next level of prescriptive analytics is the key to bending the way we think of critical care and the individualized, personalized care, and particularly pulling all the data together to do that. So I made the point that critical care is a young specialty, and it really is. And the pace of change since 1850, since the 1950s and the polio pandemic, that pace of change is incredibly rapid, and there's a number of external forces that have shaped our specialty and almost certainly are going to continue to do so, because computing capacity, the development of new technologies, and how we roll those into patient-centered care in the ICU is going to shape the way our ICUs work and the way we take care of patients. We have to continue, and particularly in the next few years, apply the evidence that we have, because we know the first thing that we can really do, the low-hanging fruit, is being able to consistently apply that evidence, because those are the things that we know, they're already proven, we know that they can save lives, they can result in better disposition and better outcomes. And then the more evolutionary part, the piece that's going to take more time, is integrating that data, figuring out how to individualize it for the person and the patient in the bed, and deploying some of these other technologies, right? So you can think about point of care ultrasound as another tool that's going to allow us to individualize treatment at the bedside. So with that, I would love to hear your comments and questions. I appreciate the opportunity to speak about this. It's really a fun topic. And I hope that I will get to see many of you in Puerto Rico in February of next year for our SCCM Congress. I can tell you that the SCCM leadership and the staff who are organizing the Congress have actually been down to Puerto Rico just recently, and it looks wonderful, not only in the space for those of you that were there before, there's a tremendous amount of new space and building for hotels and meetings and other things, but also all the things that they're putting in place for ensuring that it can be handled safely. So I'm really looking forward to that, and I hope to see many of you there. So with that, I will stop and hand it back to Rita and let you guys tell me what we want to do next.
Thank you so much, Dr. Martin, for this wonderful presentation and this this trip into the future. I am going to put up the CE survey, and we are happy to take questions right now. The questions can be typed into the window, and we'll go from there.
And I know you have a whole other agenda of things too, but I would encourage everyone. I mean, as much as I think the chapter meetings are really important, and I really do appreciate the opportunity to speak. And also, I appreciate the fact that you guys and many of the chapters are inviting people from SCCM to come and speak and share, and particularly to learn. And we've done this before in person, and I really look forward to being able to do that again, because I would certainly welcome feedback. But please, I mean, I put my email address and Twitter handle and everything up there, because I would love to hear from anyone if you have thoughts for things that we should do better or do differently.
So much. Dr. Martin, I'll start with a question I have until questions start coming in. I wanted to ask you, what advice would you give for us to stay abreast with all the technology advances that are happening? And what's a good way to actually know what's appropriate for our patients? I see two spectrums, people who 100% embrace technology without it necessarily applying to the patient population versus the other spectrum where there are clinicians who are very resistant. So what would be your advice for that?
It's a really good topic because, as you said, I mean, there's people who are early adopters. There's others who are either less comfortable with it or just less confident that they know how to use it or that it's going to help their patient. And that's all fair and correct. I don't think there's a single way. There is no single simple way to try and deploy sort of technology, and particularly because, as I said, one of the things that we're seeing, particularly in critical care, is the evolution of technology actually coming into the ICU. So, when we're thinking about all the things that exist, even whether they're Swan-Ganz catheters, PA catheters, mechanical ventilators, all those things evolve, and they evolve not because of things that we are doing in the ICU, but because there's additional technology that's brought to bear, right? So all of our smart pumps can communicate. Well, that's not an ICU development. That's a technological development that's outside of healthcare that's then brought in. So all those things are going to continue to stream in. And in some ways, I think there will always be people who are early adopters. There will always be people who are a little bit slower. The key to me is to figure out what works now for your patients or for our patients. So, for example, there's a lot of algorithms out there now that people can deploy into an electronic health record that will help you to identify patients who may deteriorate or who are going to have some untoward event. But unless they've been shown, unless it's your population, right? So unless it's pediatric or adult and it's medical or surgical or trauma or burns, right? Unless you know that it's really going to work in your patients, you have to test that and make sure that it's going to be effective, because right now it's one of those things that's sort of on the cusp of technology, and we're beginning to see it in the ICU, but it doesn't mean that we should begin adopting it and deploying it without knowing that it's going to work, because there are some that do, I don't doubt that. But there's also several, and you may have seen a report in JAMA recently that there was one of the algorithms that's out there really doesn't perform as well when it works in a real world setting as compared to how it was when it was tested in its sort of test bed.
Wonderful, thank you for that. I think, all right. I'm seeing some questions in the chat, so let me figure out to make this bigger. Okay. So with the regionalization of ICUs, what would be the estimate of total beds that may be necessary, like on a per 100,000 population basis?
Well, that's a specific question. So I don't know that I can do the math in my head, but one of the things to think about in tiered regionalization is better application of resources, in the sense that, and I say that because it may not mean that we need more beds. It may be that we need better ways of monitoring and identifying which patients are going to benefit from transfer. And remember, when we're talking about telehealth, telemedicine, or monitoring and transferring, part of the goal of those strategies is to identify the patients who can stay as well. Because if you look at everyone and say, oh, okay, fine, transfer them, that's sort of what we do now, because we're communicating, we're not necessarily seeing information, we don't have any longitudinal perspective other than what the provider on the other end is telling us. And in many ways, until we can get the data and the other elements that can help inform our decisions, we rely on the little information that may be available in either a lower resource setting or someplace else before they come into a higher resource environment. And in many ways, deploying these things together, like using telemedicine and telehealth, can help to determine which patients can safely stay where they are so that they remain closer to family in that environment, not consuming transport and resources, but also identifying the patients who maybe are more likely to deteriorate, which ones need to transfer. And we see that with the neuro ICUs in many places, right? They're looking at patients and they're looking at scans and they're looking at physiologic data, and they can say, okay, this is a patient who's at risk of several consequences, vasospasm, other things that may need other interventions, and they can identify which patients to transfer, just like we do for trauma and other things. So it's not necessarily an expansion of critical care resources. It might be deploying them somewhat differently, but in many ways, it might actually be a more efficient way to utilize them.
Thank you for elaborating on that. We have a comment that says, excellent presentation. What a great topic to provide hope and inspiration in our industry. Thank you, Dr. Moore.
I'll pay whoever put that comment in there. Thank you.
We have another question that's asking, imagine a future that upends the concept of the ICU, a place that collects, concentrates trained personnel and technologies. What patients currently in the ICU could be managed remotely at home or elsewhere?
That's another interesting one, especially with COVID, and we're all doing so much more remote work, right? I mean, here we are sitting here remotely right now. So it's interesting to think about how you could do that. And I guess that's one version of telemedicine or telehealth. And when we have cameras and physiologic monitors and smart pumps and everything that sort of feeds us a common database, there is a lot, but there's also, I think, as we all know, there's an element of human contact and evaluation, examination that goes along with that. So I don't know that we'll be able to do all of that, but very clearly, whether it's across resource settings or it's the ability to expand critical care services, telemedicine is one way to do that. I don't necessarily think that, sorry, I guess I'm trying to remember the first part of the question. What did they ask?
The question was asking if there are ICU patients that could be managed remotely based on access to the technology, et cetera.
So in some ways, I mean, we probably sort of do that now, right? I mean, we certainly have people communicate about ventilator settings and the parameters that go along with it and the dialysis machine, CRRT, and what's going on with that. So in some ways we can remotely do it. I don't see that. I guess I don't see this being a robotic ICU with no humans, in the sense that there's still a certain amount in the foreseeable future of human sort of decision making and expertise that has to go into that. Now, having said that, I mean, you can imagine that in some ways, as you train artificial intelligence or robots or whatever, I mean, they can do quite a lot. What I think is perhaps more interesting is taking that concept and saying, okay, if we're able to do those things in a critical care setting, and particularly if we're able to do it in a broader array of settings, that changes the face of what critical care looks like. Because now, even with tiered regionalization, the high intensity units are really going to be much more complex ICUs. And in fact, if you fast forward far enough forward, you'd say, well, but Greg, you said that maybe organ dysfunction and other stuff may not exist because we can predict it, we can prevent it, we can redirect the immune system to avoid all those complications. So in some ways, sepsis goes away, but so do a lot of other forms of critical illness that are most of what we deal with is organ dysfunction. So it begins to make you think that some of this will be the things that aren't avoidable, right? So the patients who have acute injuries, traumatic injuries, other things that can't be avoided so easily, perhaps, you know, major complex surgeries where patients are critically ill afterwards. But some of the things like medical illness may not be the same kinds of things that we think of now. And even things like oncologic illness, complications of chemotherapy, I mean, all those things may largely be preventable.
Interesting. Okay, our next question is saying your remarks focus on task reallocation tools and treatments. How will or must training change?
That's a good question. So some of that, and I think we all see training often changing due to the forces that come along, but not necessarily changing in advance, right? It's often reactive to what's needed or what's happening once we have new educational paradigms or new needs for certain professions, for example. Unfortunately, that's probably going to continue, at least until we get our arms or our brains wrapped around what critical care may look like in the future. There's certainly the things that we think of every day, the teamwork that goes into delivering care for an ICU patient, and the nurses, the physicians, the pharmacists, the APPs, the entire sort of professional team, which we know works. I mean, that's one of the most important components for why critical care is effective. So in some ways, you can imagine that training will become more and more interprofessional, you can also imagine, in some ways we're already seeing this, is that some of those training pathways begin to overlap and intersect, so that physicians and APPs and nurses, respiratory therapists, pharmacists will get more exposure and more training together, particularly as you get into the subspecialties. If you're going to be working in an ICU, for instance, getting that level of training together would be, I think, valuable, and would be hopefully one of the things we'll see more of.
Awesome. Actually, this question complements the same concept nicely. With changes in technology come loss in certain skills. For example, the anatomic identification of vessels for blind line placement. Any thoughts on what skills we may lose given your future scenarios, and how can we ensure to preserve those that may deserve preservation in medical training?
Yeah, that's a good question too. So I guess I might start backwards a little bit and ask people to think about the responsibilities of physicians and other providers in hospitals and ICUs in the 1950s, 60s, and 70s. Because at the time, a lot of the things like arterial blood gas sampling, NG tube placement, certainly endotracheal intubation, all those things were only limited to the realm of the physician. And increasingly, we've made them more readily accessible, or we've realized that those are kinds of things that can be taught, and they can be deployed much more readily across many different professions. So the question, I think, becomes, well, are we worried about de-skilling or loss of skills? Or are we worried about the adoption of new skills while other skills sort of get moved on to the rest of the team? And I don't think that's not specific to physicians. I can imagine, right? I mean, there's nurses and pharmacists and respiratory therapists all have their skills. And I can imagine each of those having the same, they're not going to do this anymore, but now they're going to do this because there's sort of the capacity, either because it's handled by a computer or you don't need the same manual monitoring and interventions that you do now. And so I would say, if you look back over time, we've de-skilled a lot of things, and I don't mean we've handed them off to other people. I just think they're no longer the common things that we think of as being a highly complex, highly skilled procedure or process. And I expect that the same things will continue to happen. So I'm not worried about losing skills. But I guess what I'm more worried about is how do you adopt the new skills, as you said, Rita, like these new things come along. How do you determine which technologies, and how do you make sure the provider of any profession is capable of doing that? Because it's, as we see already, I mean, there's tons of new technology in the ICU, and it's not always readily, it's not the education and competency to go with it is not necessarily available to everyone, because some people learned it as part of their training and some people didn't.
Okay, our next question is asking, to what extent will healthcare financing decisions drive your predictions?
Well, that depends on which country we're in. I think we all know that healthcare financing in the US is one of the bigger businesses around. We're getting close to 20% of GDP going into healthcare. So it certainly is. I mean, you would like to, all of us would like to think that that's not the driving force for how things will be deployed or how things will shape for the future. I don't think that's actually the major thing. And if you look back over time, technology is probably one of the greatest things that shape things. Now, technology has driven costs, and that might be sort of the related corollary problem. But one of the bigger problems we see, and it's a little bit specific to critical care, although it applies to all of hospital care, is the fascination with the new thing, the bright and shiny object phenomenon, where we have a new technology, a new device, a new drug, a new something that we feel comfortable and confident is going to help our patients. And we don't think so much about, is it really the right thing for this patient, and what are the costs, and what are the, when we think about the cost, it's not just for this patient, it's also what about the other patients, and how do we do that from a healthcare perspective, from a national perspective, or within a healthcare system? That's, I think, maybe the bigger issue. I don't know, it would be hard for me. I certainly wouldn't argue that finances are not going to play a role in all of this, but I think it's actually probably not going to be the major one, unless I think there's other things that are going to shape critical care. It's and all of healthcare, and it's not the finances specifically, but it is actually the fact that healthcare is so expensive and it's not delivered to, equitably across people in the United States, because that's probably the biggest thing. And if you think about what critical care might look like, we can't eliminate sepsis and organ dysfunction, all that, if you can't take care of people at the very sort of beginning of an illness.
Right. We had another comment/question saying, I know you mentioned bundle compliance helps improve outcomes across many types of protocols. How do you push compliance in a time where burnout seems so prevalent, where more than it's ever been, without coming across as asking too much of the staff?
Yeah, that's a really good one, and I appreciate it, because I think we're all experiencing it. We're all living a period of burnout, lack of wellness, and in some ways really uh, really negatively affecting resilience, which is probably the biggest factor for how people can thrive or flourish and obviously be sustained as a profession and work in the ICU. Because we all know that burnout and the factors that go with it were high in critical care before COVID-19. They're much higher now. There's some really interesting surveys, and some of them I'm sure you've seen. They've been published in the critical care literature, which shows changes over time. And there's some things that have gotten remarkably better. We don't have as much concern about drug shortages and PPE shortages and other things, but we still have a lot of concerns about the best ways to take care of patients. How do we manage our family? How do we manage our life? Things like that continue, and particularly those are impacting women more than men, largely because of child rearing and family care and other things that go along with it that often are more familiar or end up in the woman's lap as opposed to men. Sorry, so it's, I guess, thinking of sort of where we go with that. The point that I would make is that as that technology and all the things that we have should be able to support it, but now it's probably not the time to try and do this. And I say that because if you think about, how do we achieve our successes in, the consistency in multidisciplinary rounds, or how do we ensure that we're consistent in the application of a policy or a protocol for something that we know is important? You don't do it when the patient arrives in front of you, right? You have to do it at another time. And so as much as I want to see all the elements that we know as ground truth evidence of things that will improve patient care, now may not be the time to try and develop that new policy or protocol in your hospital or your ICU, because there's other things that are more important. And the last thing you want to do is add another burden on top of all the things that are going along. Now, we all want to provide good COVID patient care, and that's one thing. Like, we have policies and protocols and things that I think help with that, and those need to keep evolving because there's new things that come out. But if you were to say, oh, let's try and tackle a new strategy for multidisciplinary rounds, I would say you can do that, but start really small, right? I mean, you don't want to try and say, okay, let's all get together and we'll do this every day, we'll do it twice a day, it's going to be great, because it's just too much of a challenge right now. So be thoughtful about what's going to help, and build into the back of your mind the things that are going to not just support that, but also build the resilience and wellness component. Because if you tie those things together, you can figure out how a policy or a protocol or a bundle or whatever deployment is actually going to help the people involved in it, then that is incredibly valuable, because that's now supporting wellness and everything else at the same time.
Oh, so much for that insight. I think we're all sensing the burnout and the stress, but seeing patients hopefully get better, and we are definitely light years away from where we were last year, and hopefully with increased vaccination, et cetera, we can continue to build on that and ease the pressure that everyone is feeling across the country. We thank you so much for this very interesting talk, Dr. Martin. Your presentation was extremely interesting, but I think the discussion that we also had afterwards has been extremely enlightening, and it's definitely something that we don't think about day in, day out, but it's very interesting to see where we could be in 10, 20 years for all of us who would still be practicing then. I would like to thank you on behalf of the chapter, on behalf of all our audience. I'd like to thank all our audience also for attending. Please make sure to submit your CE survey within the next 2 weeks. The deadline is September 6th, and we will see all of y'all on October 14th with our next quarterly meeting. Thank you again so much for taking the time to present to us and for taking the time to attend. Everyone, please have a good night.
Good to see everyone.
Thank you.
Stay safe and stay well.